Go ahead and introduce yourself, Dr. Mays, and we'll get started.
Hello, everyone. I'm Justin Mays. My screen probably says William, but I go by my middle name. I'm the infectious diseases pharmacist for WVU Medicine at Thomas Hospitals. Today, I'll be doing a presentation, short and sweet, about C-Diff, Clostridioides difficile infection. My colleague Katessa, who's also in the call, did a presentation in June about shorter is better for intra-abdominal infection. So I decided to approach this from, if we be vigilant in our antimicrobial stewardship efforts, sometimes we do end up with patients that unfortunately end up with C. diff. So approaching it from how we deal with C. diff if we do have a patient who acquires. So move on to next slide. So two objectives today. So identifying risk factors associated with the C. diff infection, and second objective being reviewing appropriate antimicrobial treatment modalities for C. diff in both adults and children. So this is just an audience question. I know a bunch of my colleagues are in here, so they probably know the answer, but just out of curiosity, if you want to put it in chat, how many C. diff infections per year in the US would you estimate that we have? Or you can shout it out. I think Dr. Juskovich said something, but I can't hear. See, Rachel saying C. Okay, we'll go ahead and move on. And Rachel, you're correct. So this is monitored by the CDC, specifically the National Center for Emerging and Zoonotic Infectious Diseases. Actually 500,000, so 500,000 infections per year with C. diff. Next slide. So a little bit of background. Some of us probably learned originally as Clostridium difficile. Clostridioides was reclassified in 2016. This is a gram-positive anaerobic spore-forming bacterium, also toxin-producing, and that toxin production is what leads to the pathogenesis of C. diff. Toxin A being enterotoxic and toxin B being cytotoxic. Clinical symptoms of C. diff vary from mild diarrhea to pseudomembranous colitis and toxic megacolon with septic shock. As far as epidemiology, we already kind of touched on the 500,000 infections per year in the United States. It is the primary causative agent of healthcare-associated post-antibiotic colitis. Patients who are infected with C. diff, 1 in 6 will have a subsequent infection within 2 to 8 weeks, and then 1 in 11 patients that are age greater than 65 diagnosed with C. diff will unfortunately die within 1 month of that diagnosis. Next slide. Here are the primary risk factors for C. diff and C. diff recurrence. Starting at the very, very top with our antimicrobials. If you can remember the 4 C's of C. diff, so 3rd and 4th generation cephalosporins, carbapenems like meropenem, ertapenem, clindamycin, and then fluoroquinolones. If you can remember Cipro, that's a really easy way to remember your fluoroquinolones. Advanced age and immunosuppression kind of go hand in hand. So as we age, immunosenescence and decline in immune system, as well as patients who are immunocompromised. The reason being is these patients are more likely to be exposed to the healthcare system and be exposed to antimicrobials, so they're at a higher risk of C. diff acquiring. Previous C. diff, because if you have previously had C. diff, more than likely your gut flora has already undergone dysbiosis, and you're at higher risk of a recurring C. diff. And then proton pump inhibitors, so this would be like arameprazoles and pantoprazoles. This is because they lower GI acidity, and that allows overgrowth of C. diff as well. Next slide. So this was a take on oral antibiotics. So this was done by Miller and colleagues. This is part of the CDC's M&I group. They look at hospital-acquired infections. This was published back in 2023. This was a study looking at Medicaid and Medicare diagnoses from 2001 to 2021. This was about 160,000 CDI cases and looking back on what antibiotic was associated with those. And it kind of goes hand in hand with those original risk factors that we get from guidelines. So clindamycin and later generation cephalosporins were the highest risk factors for CDI. I know it's kind of a tiny graph to see. I try to squeeze it all on this one slide here. And they actually found the lowest risk was associated with minocycline and doxycycline. So as the more expanded coverage you get with your antimicrobials, the more likely they are to disrupt your GI flora and potentially lead to CDI. Next slide, please. So moving on to treatment, going off our most recent guidelines of the 2021 update, what is the preferred first-line antimicrobial for an initial episode of CDI in an adult? Ooh, quick answer to C. Yeah, so everybody's putting C, so that is the correct answer. So we'll go through treatment here. So this is for, we're going to start with adults and then we'll move on to our kiddos. So initial CDI episode is with fidaxomicin. This is a macrolide antibiotic. So it has low systemic absorption and is highly concentrated in fecal content, so it's ideal for treatment of C. diff. However, alternatively, you can still go with vancomycin 125 milligrams every 6 hours for 10 days. And if you hit it one more time, a little graphical reason as to why. And that has to do with cost of fidaxomicin. So there was a study done in 2020 through 2022, cost analysis of fidaxomicin, and they found the average to be about $3,100 for a course of fidaxomicin. They found as low as $2,300 and upwards of $5,000. So this kind of depends on your institution, what contracts you have, what distributor you have, depending on what cost you can get. But a lot of times this leads to poor implementation just strictly due to cost, which is why in guidelines they still offer vancomycin as an alternative because it's much cheaper. There are some patients, if you have a non-severe CDI infection, you can still get away with metronidazole. And non-severe CDI is defined as a white count less than 15 and a serum creatinine less than 1.5. However, they do note that recurrence rates are still high if metronidazole is used as an initial treatment plan. Next slide. So moving on to reoccurrence. Essentially, train of thought, whatever you tried first, move on to something different the second go around. So preferred is fidaxomicin twice daily for 10 days, or you can do a tapered regimen, so twice daily for 5 days and then every other day for 20. You can do a vancomycin tapered and pulse regimen. They do give an example here, which is essentially 4 times for 10 to 14 days, and essentially you cut it in half every 7 days until you're out for 2 to 8 weeks, depending on the severity with whatever physician has prescribed. Alternatively, if you use metronidazole the first go around, vancomycin would be your next step up, and that's just your standard vancomycin regimen. And then also an adjunct treatment for prevention or reoccurrence would be bezlotoxumab. Bezlotoxumab is a human monoclonal antibody that targets toxin B with C. diff. There's just a small warning. The FDA warns that if you have a patient with history of congestive heart failure, just use with caution. They found in studies that this can lead to an exacerbation of CHF. The mechanism is not well understood. It's likely to be multifactorial, but that is just a warning there. Next slide. And then we move on to second or subsequent CDI recurrence. Again, same mentality here. Whatever you try the previous go around, try something different this go around. The only real difference is then at this point in time, you're looking at fecal microbiota transplantation. There are some institutions that do this just strictly on their own. The FDA warns that, especially back in 2020, there were some instances where patients were getting transplanted with things like pathogenic E. coli. So there are products now that are FDA indicated, things like Rebiota or Voust that you can use for this. And again, same adjunct treatment with bezlotoxumab. Next slide, please. And then we move on to fulminant CDI. So this is hypotension, shock, ileus, megacolon. These patients are typically in the ICU looking for some sort of surgical intervention. For this, vancomycin, your dose changes up to 500 milligrams. You can give this by nasogastric tube every 6 hours. If there's an ileus, consider instillation of rectal vancomycin. So this is 500 milligrams, usually in 100 mLs of normal saline as a retention enema. And then metronidazole IV every 8 hours given together. Next slide. And then we move on to our smaller humans, for those of those who take care of children. Children were not updated in the 2021 updates for C. diff, but along the concepts are still relatively the same. Metronidazole or vancomycin is your initial. Pediatric infectious diseases does recommend vancomycin nowadays. Reason being is because they found metronidazole has a 5 times higher instance of recurrence in children versus vancomycin. Again, has not quite made its way into guidelines, but there are good studies coming out to support that. Initial episode for severe, same with adults. So vancomycin, either orally or rectally, plus or minus metronidazole. First reoccurrence, same concept, whatever you started with, try something different, and then your second and subsequent reoccurrence doing those pulsed regimens. I did not include fidaxomicin on here. There is pediatric dosing with fidaxomicin, but again, not quite made its way into guidelines yet. And again, pediatrics are your weight-based dosing found in the third column there, and we do not exceed max doses for pediatrics as we would in adults. So you all already knew the answer to the question to begin with. So again, the answer was C. Chaitra, if you hit one more time for me. Again, fidaxomicin, just due to its potency, should be utilized as first-line agent for the first episode of CDI. However, they do recommend if you're unable to implement due to cost, vancomycin is an acceptable alternative. It looks like we have a question. What are your thoughts on transitioning from fidaxomicin to vancomycin if patients still symptomatic but somewhat improved after 10 days of fidaxomicin? So we actually have an inpatient guideline that talks about this for WVU. If your patient starts out on fidaxomicin and cost is prohibiting the patient from being discharged, depending on physician discretion, and Dr. Duskovich, sorry if you have any comments on this as well. From our standpoint, you can transition them to oral vancomycin. I don't know if you all have a take on that as well.
I would agree with the transition to the oral vancomycin, especially for the younger patients. I think the one way I frame it is, yes, fidaxomicin is better, fewer relapses, but it's so expensive and it's harder to get. So the next question becomes, if I have a younger patient, 30-year-old, whose risk for relapse C-Diff is lower, that's the kind of patient, if they're getting better on the fidaxomicin after a couple of days, change to vancomycin, and that's a little easier to discharge on. But the challenge becomes, what do you do in the 75-year-old? Because that's the age group at which the risk for relapse C-Diff is very, very high. Do you not use the fidaxomicin up front and then deal with the relapses subsequently, or try your very best to get the fidaxomicin up front?
I guess my question was more for, I had patients who, after 10 days of fidaxomicin, instead of having 20 loose stools, now they only have like 10 or 8. And they want to know if, should we just stop treatments and see how they do, so they keep improving after completing the course of fidaxomicin, or do you transition to PO-Vanc? Typically, I've been transitioning. I'm doing PO-Vanc, even though there's no guidelines for it. Don't know if they kind of failed it or what the reason is, but they seem to get better with that. But just curious your thoughts.
I haven't experienced that particular scenario, so would love to see what others do in that situation.
I say I've not encountered this myself. We've had some patients on a regimen and they were slow to respond. So instead of stopping at day 10, we extend it a little closer to 14 days. That seems to be okay from our perspective with my ID practitioner here. I don't know about either one of you, but or anybody else on the call, but we've done that, but not just a direct switch over to something else. I've yet to experience that.
I think we see it a lot, or may get called about, is the indeterminate C-Diff.
Yes.
The clinical question, I've kind of gone back and forth on, say it would be a relapsed episode, but the PCR is positive, toxins negative, they're having some diarrhea, and we recommend fidaxomicin because it's a nice kind of short course, but then they're not able to obtain it or it's not affordable. Do we subject that type of patient to the prolonged oral vancomycin taper, or do we kind of guess how aggressive to be at treating those types of patients when it's not as clear cut, but maybe they are having some diarrhea?
I think the guidelines are they leave it on clinical decision making. Theoretically, a PCR positive toxin negative result is negative. I mean, it's toxin negative, so one should not be chasing it. But for patients who are symptomatic and high white count, I think most of us go ahead and empirically treat as though that's real C. diff. Mhm. There was a time about 5-10 years ago when we were at this institution seeing a lot of fulminant C. diff ending up with total colectomies. I think that has decreased, at least for our institution. Wonder what others' experience is. Are you seeing a lot of colectomy needed for fulminant C. diff?
I know you've given it the one recent patient was back in August that I learned from.
All right. Do we have any other questions or comments regarding this presentation?
So Joy was asking the question about why are we seeing less, one of the advantages of being in a place for a long time is you get to see the history over a couple of decades. The strain of C. diff that was responsible for the total colectomies was the NAP1 strain. That was the epidemic hypervirulent strain that produced toxin A and B in quantities 1,000-fold higher than what was the previous endemic C. diff strain. And I've seen fewer cases of that over time. So, to me, the explanation for why fewer total colectomies is the predominant prevalent C. diff strain is no longer that epidemic NAP1 strain that actually started from Canada and then disseminated throughout the US. And the pathophysiology of that one had been very well worked out. It had a mutation that produced 1,000-fold higher levels of toxin A and B, and that's why you saw fulminant C. diff with that.
Do we have any other questions, comments, concerns, anything else before we go to the case?
Do you have my case?
I do.